What I would do is I will give you an overview of what Nottingham has been doing during the COVID sort of period, give you a flavour of some of the things that we've done over the last few months, and also some of the things we hope to do moving forwards. I'm aware there's a very mixed audience. Some of the slides might look a little bit technical, but I will try and talk you through them. I'm very happy at the end of this to answer any specific questions that you may have. So the first challenge is, can I get the screen sharing to work? So hopefully, let's just have a look and see. So we share that. So hopefully you'll be able to see some slides. I'll just get the, are we there, Kate? Can you see that?
We are there. That is
excellent.
Perfect.
That's a good start. So my name's Ian Hall. I am a chest physician based in Nottingham, but I also, as Kate mentioned, am the director of our Biomedical Research Centre. And I guess many of you know about the Biomedical Research Centres, or BRCs as we call them. And there are getting over 20 of these around England, and they're funded by the National Institute for Health Research, NIHR, and they're designed really to provide the infrastructure to support clinical research. And so clearly, when COVID came along, the BRCs became an important part of the landscape to enable us to do research into COVID. But the BRCs existed long before COVID and have been historically doing research in a wide range of areas. So in Nottingham, as many of you will know, we've had a particular interest in respiratory diseases, gastrointestinal diseases, hearing research, imaging research, mental health and research, and musculoskeletal research. Those are the main themes within our BRC. But obviously what I'm going to be talking about mostly today is the work we've done around COVID. So I guess I first became aware of COVID back in January, and I have by chance a PhD student who is a chest physician based in a city called Ningbo. So those of you who are in Nottingham will know that Ningbo is a city which we have close affiliations with. There's a campus in Ningbo run by, with Nottingham University, and I've made a number of visits to Ningbo to look at the opportunities to do joint research projects in the city. And this is a picture of a chap called Dr. Ryan, who's a radiologist from Ningbo First Hospital, who visited Nottingham about 18 months ago as for some postgraduate training. And together with another colleague, Dr. Kian, who is a chest physician in Ningbo First Hospital, they alerted me actually to the first cases that were coming in initially Wuhan province. This is back end of last year, and they started to see cases in Ningbo city, and very helpfully sent through some information about these patients. At this stage, there hadn't been a case in the UK. And what I'm showing you here is a CT scan of one of the patients who presented to Ningbo hospitals back in January with really with what was at that stage a new disease, which was a nasty viral pneumonia, which went on in some patients to cause significant low oxygen levels, requiring treatment on an intensive care unit, and at that stage quite a high mortality. I think you should be able to see the arrow on my mouse here, and what you can see on this scan, for those who aren't used to looking at them, is the lungs should look nice and black like they do around here, but you can see all this horrible white stuff at the back of the lungs on both sides here, and these are the features of a nasty viral pneumonia. And so this was the first we became aware of this, and at that stage, of course, there hadn't been any cases in the UK, but then partly I think as a consequence of people heading off on skiing holidays in Italy, where there had been a fair number of cases, obviously we started to see cases accumulating particularly in London, actually, at the end of February, beginning of March, and that's led to obviously the pandemic as we all know. So this is the current state. I downloaded this earlier today from the government's data website, and just to sort of remind you of exactly where we are. And these are figures which are shown as rate per 100,000 in the population. So as of the 20th of November, which is the data which is available on the website, I think they just released this week's data actually, but there were around 18,000 people testing positive each day in the UK. You'll notice that the number of tests in the spring looks relatively low, and that's because we weren't testing very many people, and there's much more testing going on, which is why the rates look higher now. And you'll also notice from the green bit on this panel that the rates are starting to fall off as a consequence of the restrictions that have been introduced over the last 3 or 4 weeks. One thing to point out for those of you who aren't used to looking at this sort of information is that there is a lag between someone testing positive to them potentially needing to go to hospital, and if they get very sick with this disease, ending up on an intensive care unit and dying. So when you start to see the number of cases going down in terms of the tests, you wouldn't expect to see a change in hospital admissions for 10 days to 2 weeks until 10 days or 2 weeks after that. And similarly, you wouldn't expect to see a reduction in death rates or anything for another 2 weeks after that. So there's a lag in all of these figures. And as a consequence of that, if you look at the next panel along, which is the panel which shows deaths within the last 28 days, you'll see that, and this is actually data from the 25th of November, actually, when I look at the panel there, you can see that these haven't started to go down, although there's a hint they're leveling off. And there's still, you know, this is a nasty condition. There is still getting on for 700 excess deaths as a consequence of COVID-19 happening on a daily basis. Then we've got the hospital admission data, and interestingly, the death and the hospital admission, because obviously most people who got very sick with this ended up in hospital, show a slightly different picture from the test data. You can see this large peak that happened back in the spring after Easter, and you can see that actually the numbers of people getting admitted has been less in the autumn, suggesting that there were lots of people out in the community who had this condition who we weren't seeing back in the spring. And in terms of the deaths, although that isn't flattening off, if you look at the patients admitted, that's starting to flatten off, suggesting that the drop in the number of cases testing positive is being reflected in hospital admissions. And my prediction, both nationally and for the Nottingham area, is that these numbers will drop off, assuming we continue to obey the tiered restrictions that are coming in early December. And the other thing you can see here is that the massive increase in testing that's gone on. So we're now doing about 1/3 tests per day in the UK. In the last week, there were 2.3 million tests done for COVID. And that is the reason why we're seeing these much larger numbers of positive tests compared with back in the spring. So that's what the data look like and where the projections are likely to be going over the next few weeks. And of course, that is the national figures, and that's somewhat different from the regional picture. And as we all know, the Nottingham has been in tier 3 and is likely, will be staying in tier 3 actually when we move to the new tiered restrictions as of the 2nd of December. But unlike in the spring, where the vast majority of cases were down in the London area, in this second wave, what we've seen is most of the areas where there have been a large number of cases have been in the northeast, the northwest, the central belt of Scotland, and actually the Midlands as well. So we've actually had more hospital admissions with COVID in the autumn than we had back in the spring, and we've currently got more people on the ICU because of COVID in Nottingham than we had back in at any stage during the spring. So a mixed picture. And if you're lucky enough to live in the Isle of Scilly or in the Shetland Islands, where there aren't any cases at the moment, you can carry on having a relatively unrestricted existence. But obviously, large parts of the country are going to end up in tier 3 or tier 2. In fact, pretty much all the country will end up in one or other of those tiers as we move forward into the new tiered restrictions on the 2nd of December. So the National Institute for Health Research has set up a priority list because obviously the challenge for us has been to continue to do research into all of the conditions that we usually do research on: cancer, heart disease, chest disease, etc. But at the same time, trying to run all the COVID research, which has been a major challenge for us to manage actually. This is a rather wordy a slide, but you don't need to read through it. But it's just to point out that there are 4 4 levels of priority in terms of what we are being asked to do. And the top priority is to do the COVID-19 vaccine and the most important of the drug studies, and that includes things you probably heard of, such as the recovery study and some others like Principle and REMAP-CAP. And then the lowest level in terms of the priority is all studies which don't involve COVID, or some COVID studies which have been deprioritized for one reason or another. And I just point out level 2 in here, which is, so these are studies where the research protocol includes an urgent treatment or intervention without which patients could come to harm. And this includes a lot of non-COVID research. And a typical example here might be a cancer trial where access to a given treatment is important to maintain. So those are still being prioritized, but you can see they're slightly lower than the COVID priority studies in terms of the priority order at the moment. So if you were to ask me what the key research questions are about COVID, this would be the sort of list I'd come up with. I'd say we still don't really know all the details about how the virus is transmitted between people, and most importantly, what the most effective ways are to prevent transmission. So all of the social distancing that we have in place and all of the restrictions that we put in place are based upon modeling data and assumptions about how the virus is transmitted. But actually, do we really know exactly which is the highest risk? Is it going to the pub when it's crowded? Is it going, is it going to church? Is it going for a walk in the park? I mean, we think we know, but actually there are still some important questions to ask about that, I think. From a medical point of view, one of the biggest challenges is to diagnose COVID-19 as rapidly as possible, because what you want to do is to make sure that patients who've got COVID-19 are looked after in a hospital setting where there are other patients with COVID-19. And what you don't want to do is to put patients who've got COVID-19 in a ward where there are lots of patients who don't have it, because obviously then there's a potential for them to pass it on to somebody else. So a really important thing for us has been developing rapid diagnostic tests so that we can identify as quickly as possible when somebody pitches up in the A&E department whether or not they're COVID positive. I'm going to say a bit more about vaccines because Nottingham has been involved in some of the vaccine studies, but obviously having an effective vaccine has been in the news a lot recently. And this, from my point of view, is the light at the end of the tunnel. It's the exit strategy for us all. We know a bit more about effective treatments for acute disease. I'll talk a little bit about that. What are the risk factors for long COVID? So long COVID is a phrase I guess most of you will now have heard of because it's featured widely in the press. But this refers to patients who've had COVID but who are continuing to get symptoms some stage after the initial acute illness has passed. And we still don't know, of course, what the long-term consequences of having COVID-19 are. Most people have a very mild illness and get better very quickly, of course, but some people seem to go on to have some long-term complications. And for those people, we really need to try and define what the most effective interventions are to give those people the best chance of recovering as effectively as they can do, particularly from this long COVID I've just mentioned. So I'm just going to share some information about what we've been doing locally in respect to some of these challenges. These are nearly all part of large national studies, but I thought you might find it interesting to see a little bit about what's been happening in Nottingham. So if we're looking at the transmission, these are some studies that have been ongoing within Nottingham. So a colleague of mine, Ben Oliveri, who's a trauma surgeon here in Nottingham, has been, ever since the pandemic started, screening large numbers of healthcare workers, looking to see whether or not they have an antibody in the blood, that's what serology refers to find out whether or not they have been exposed to COVID, so that we can understand a bit more about how the virus gets passed around amongst healthcare workers. I was involved in work in the university where we set up a screening service through all the halls of residence to try and identify those students who were COVID positive. 60%, 80% of these students were asymptomatic. So clearly identifying those people who were positive at an early stage was going to be the most effective way of preventing those individuals passing the virus on to other people. And that's been a major challenge. At one stage, getting on for half of our students were having to self-isolate, either because they had COVID or they had been in close contact with somebody who had had it. At a more sort of laboratory-based level, we've been doing work where we take the samples of the virus from individuals who've been infected, and then we sequence the genome of that virus. So what that does is it gives you a genetic fingerprint for that particular virus, and because different strains of the virus are slightly different, it means that you can trace potential outbreaks back to an index case, and you can see whether or not what we're seeing is lots of people bringing in different versions of the virus in different places, or whether we're dealing with one particular strain of the virus which is spread amongst everybody within the local population. And what I can tell you is that the vast majority of cases we see come from little clusters, so it looks like lots of people are bringing the virus in from different places. It's not just that there's one person who's going around infecting the whole of Nottingham with COVID. And I've already mentioned we've been interested in assessing new point of care tests to try and get rapid diagnostic, rapid diagnoses, and those have been both the PCR, which is the sort of genetic material based test, and or based on the presence of proteins in the virus, or what are called antigen based tests. So I updated these data on the slide from this morning just to give you an idea. So these are some of the national core studies which we've been involved with, and some other studies as well. So recovery is the one everybody's heard of. As of this week, we'd recruited nearly 400 patients into the recovery trial. Nationally, the number's over 17,000 now. Remap CAP is a study which is particularly focused on the management of patients on the critical care environment, and we've recruited over 60 people into Remap CAP. So these are people who've been on ICU who've agreed to take part in studies. Synergen was a study we ran in the spring. We only recruited 6, but it's a very complicated study involving a novel experimental medicine approach, and that's some of you may have seen the press releases about this study, which involves a sort of drug called interferon, and we're just about to restart some more experimental medicine studies in Nottingham under a platform called Accord 2. So that's actually people who have agreed to participate in interventional studies to try and come up with better treatments. This is a complex slide for those of you who aren't medical, but it's actually taken from the New England Journal of Medicine paper looking at the recovery trial, and it shows the effect of dexamethasone. So I'll just talk you through this, and perhaps if we just look at the top panel on the left here. So this shows what happens to everybody in the study who was either randomized to receive normal care or randomized to receive dexamethasone, and it's looking at mortality. So you can see, and these are patients who were in hospital, so they were all sick enough to need to come into hospital, and you can see that overall, with usual care, we had a mortality rate that was over 25%, but there was a significant reduction with dexamethasone. What we found was that this improvement was seen in those patients who needed oxygen treatment or who needed to go to intensive care. So the next panel shows the intensive care data, and you can see here if you were ill enough to go to intensive care, overall the mortality a month was 40%, but if you got dexamethasone, it was reduced by a quarter. So these were the first data from any clinical trial done anywhere in the world demonstrating that we had a drug that was effective in treating COVID. And it's as a consequence of patients in Nottingham and in all the other centres across the UK agreeing to be recruited into the recovery study that we were able to produce these internationally hugely impactful findings demonstrating that giving anybody who needed oxygen treatment with dexamethasone not only improved their overall outcomes, but it actually saved their lives. And so that has resulted in changes to guidelines on the treatment of COVID, which have now been adopted pretty much across the whole of the world. I'll perhaps skip through this slide, but it's just to make the point that although recovery has recruited all of the patients for the dexamethasone arm, we've got a definitive answer on that. It's continuing to look at a whole range of other treatments, including convalescent plasma, an antibiotic called azithromycin, some antibodies. And so this study is continuing. We're still recruiting into it, and there are going to be some new arms opening up in recovery imminently, which I'm aware of. So this will carry on all through the winter. So as well as the treatment studies, we are trying to learn as much as we can about COVID-19, and we do this through what are called observational studies. So these are recruiting individuals who consent to have their healthcare records accessed so that we can find out what's happened to them. We can look at all of the laboratory tests that they've had done, and we can also take additional samples and use those for specific research projects. And the biggest of these is a study called ISARIC, which is led by the University of Edinburgh. And you can see that we've had over 1,700 recruits from Nottingham into the ISARIC study, and I can tell you that isn't absolutely everybody who's come through, but it's the majority of patients who've ended up in hospital with COVID over the last 7 or 8 months. We've also got some more specific studies. So we've got a large study looking at the psychological impact of COVID. That's 600 people recruited into that. Pan-COVID has been recruiting women who are pregnant, who've been admitted to hospital for whatever reason, and have turned out to be COVID positive, to look at outcomes in pregnancy. And then we've also been looking at what happens to people who were severely ill for other reasons in the palliative care setting, to find out what happens to those individuals when they have tested a positive with COVID. So, and these studies are starting to report now. I'm not going to go through them all because we haven't got time to do so. And this is another rather scientifically complex slide, but this is the first proper study looking at genetic factors, and I'm not going to run through this in any detail. If anybody's interested, I'm very happy to answer questions about it. But the top panel shows something called a Manhattan plot, and the thing you're interested in is these peaks on it, because they show there are parts of our genome which contain genes which increase or reduce your risk of having COVID. And what you can see is this big signal here on chromosome 3 around a gene called FICO1. So we're starting to get some information about what makes people more or less susceptible to developing COVID. You'll have seen all the stuff, I'm sure, in the media about if you're overweight, if you're elderly, if you're male, if you're from an ethnic minority background, you're more at risk of severe COVID. But some of that is going to be driven by genetics, and we're starting to understand what these genetic factors are. And the reason that matters is if you know what the genetic factors are, they potentially suggest drug targets which you can start to develop new treatments against. And obviously you can also use it for potentially looking at risk profiles. So next, vaccine studies. So we've been involved in the Oxford study. We recruited over 500 individuals into the phase 2 of the Oxford study. This was run in collaboration with the University of Nottingham, and in fact the recruitment was done at the Cripps Health Centre on the campus. And many of you will have seen the press releases. So the papers describing the actual data both on the Oxford and the Pfizer vaccines have not been put in the public domain yet, although I know that both Oxford and Pfizer have filed with the regulators to get the vaccine approved, and we expect a decision within the next 2 weeks. But what we do know is that these vaccines do produce an antibody response, which is what you would hope a vaccine would do. So this isn't looking at cases, it's just looking at antibody responses. And if we just look at the third panel along here, this just shows what happens if you were given the vaccine in terms of the levels of your antibodies. And what you can see is that after about 2 weeks, you start to see an increase in antibody levels, and out at, in this case, 56 days, you've still got significant increases in antibody levels. And the levels of antibodies that you see are similar to that you see in patients who've had disease, which is the panel on the right-hand side here, suggesting that the response to the vaccine is equivalent in terms of inducing immunity to the response to the disease itself. And although there are a very small number of cases reported of people having had COVID-19 twice, in general, if you've had it and you've had a good antibody response, you're pretty unlikely to get it again, at least within the sort of time windows which we're aware of at the moment, which is obviously about 9 months. So that's the vaccine study. We're going to be doing another vaccine study in Nottingham in the spring, a different vaccine, because obviously it's useful to have more than one vaccine available. So for the last sort of part of this, I'm going to talk a little bit about long COVID. So I've probably got about, just to give Kate the heads up, about 10 minutes to go on this, and then we'll assuming we're okay for time, then we'll hand over to any questions that come in. Is that okay, Kate?
Absolutely, yeah.
Very good. Okay, so long COVID is a term which has been used to describe patients who've had COVID who continue to have symptoms after the acute phase of the illness has passed. And I'm aware, both from people I know personally who've had COVID, and also from a lot of data from national and international studies, that a significant proportion of people still have symptoms 3 or even 6 months after having had COVID. And the classic ones that are being described are of fatigue and tiredness, ongoing breathlessness, what's sometimes called brain fog or difficulty concentrating. And there's a significant mental health burden as well, with people describing anxiety and depression. And that's particularly been a problem who've had pre-existing mental health problems, I think. We've got, as many of you will know, particular expertise in Nottingham in the imaging space, particularly magnetic resonance imaging, which Sir Peter Mansfield received a Nobel Prize from Nottingham, as I'm sure everybody on the call knows. And so one of the bits of the university we were able to get up and running at a very early stage when we were able to reopen the labs were our imaging facilities. So we've been doing a number of imaging studies looking to identify changes caused by COVID-19, which might explain some of these symptoms. And by understanding the mechanisms underlying long COVID, the hope is that we'll be able to come up with some interventions which are going to reduce symptoms and hopefully improve disease with time. And that's work that's ongoing. So the first point to say is that you can learn quite a lot from imaging studies. So COVID causes pneumonia, everybody knows that, but actually it affects multiple organs in the body. And this is just an MR image taken from, it's actually an American study, looking at the brain, showing significant changes in the brain in patients who've had COVID. So it causes inflammation in the brain as a take-home message to take from there. So these data are taken from the Zoe tracker app. Some of you on the call might be involved with this, but what Zoe has been doing is there's about 2 to 3 million people across the country who've been recording their symptoms on a regular basis and provide their data back to Zoe. And these data are hosted nationally in Swansea, actually, at the SAIL database as part of an initiative through a study called Breathe, which I'm involved with on the, and these just show the number of people who continue to have symptoms. And the bottom line is most people's symptoms are very short-lived. Most people will get back to normal pretty quickly, particularly if you're young, otherwise young and fit. But a significant number of people have got symptoms out beyond 30 or 40 days. And so we think that on average, something like 1 in 20 people have ongoing symptoms and therefore qualify essentially for having this condition called long COVID. The elderly seem to be at higher risk of developing this, but actually some young people have it as well. And there aren't any obvious clear differences between males and females in terms of who goes on to develop it. So it became very clear to us back in the summer that these patients were going to require both research projects to be set up to understand more about what the condition actually was. But in addition to that, we needed to have in place some ways of looking after this patient, because at that stage there were no clinics or anything in place to manage it. So we established something called NORCORP, which is the Nottingham Recovery from COVID Research Platform. And the idea here was that we would have, we would fund, we'd seed fund a number of research studies looking at different aspects of COVID, long-term COVID, and hopefully that would get research up and going and allow individuals to get some initial data which would enable researchers to then make the case to get longer term funding. And alongside this, we were trying to set up some improved clinical services to manage patients. So anybody who's had a hospital admission or been to ICU with COVID will be offered a follow-up appointment. But we were aware there were lots of people who never came to hospital but continue to have symptoms. And so we set up a research clinic based around primary care cases as a consequence of this. And this was launched, as you can see from this slide, on the 15th of July, and has actually attracted quite a lot of interest, and has been pretty successful, I'm pleased to say, in terms of starting studies which have gone on to get sort of national funding. So one of the studies we were keen to facilitate is something called post-hospital COVID, or FOS-COVID. And this is a study which is happening across the whole of the UK, looking at the long-term effects of COVID, and it involves a whole range of assessments. And Nottingham is the lead for the lung fibrosis strand of FOS-COVID. And as of the other day, I think we'd recruited 19 people into this already. But as I've already said, it's not just the lungs which are affected by COVID. And one of the studies we've been doing in collaboration with Uppsala University in Sweden and colleagues in Derby working on the renal unit there is looking at the consequences in the kidneys of having had COVID. So, so our collaborators in Sweden have been able to actually put people into an MR imaging machine on the intensive care unit in Uppsala, which is quite a complicated thing to do, for reasons which I'm happy to explain if anybody's interested. But this enabled them to generate interesting data looking at blood flow into the kidneys and how that responded to fluid challenges, etc. And we've been analysing their data, and we've been doing follow-up studies based mainly on patients in Derby, actually, using using MR imaging in the Sir Peter Mansfield Centre to try and understand why the kidneys seem to be affected by this condition. We've been looking at a study to try and bring together all these data sets as well, called Co-Connect, which Nottingham is the lead for. My colleague Phil Quinlan is the head for this. And this aims to bring together data sets such as the one I've just described, but actually all of the data sets relevant to COVID research, which helps us to so one of the problems has been trying to coordinate all of the activity that's going on across the whole country. So Co-Connect aims to do that. And we've been helping support some of that through NORCORP at a local level as well. So Charlotte, who's on the call, is the lead for something called the Dynamo study. And this is looking at some of these aspects to do with fatigue and breathlessness. So we're using some complicated methods to look at the way the muscles function. This is using both magnetic resonance imaging, but also some biochemical assessments that you can do using magnetic resonance. And we're doing this by looking at skeletal and muscle strength and fatigue, etc. So these studies will be going on over the next year or so. Something called the Dynamo study, which again we've supported through NORCORP. And the other thing we've done is we've been collecting samples from patients who've had COVID-19 going through our hospitals, because one of the things that you find doing research is that it's really useful to have blood samples to go back to from individuals who've had COVID, or indeed other samples, so that we can do further analyses as we go to learn more and more about this condition. And these data are a couple of weeks out of date now, but we started this in the late summer, but we had over 100 patients now who've been recruited and provided a number of blood samples, and these have been taken for a whole range of purposes. We can measure proteins in the blood, or we can measure genetic factors in these samples. And we also have consent to link those to health records so that we can look at the long-term consequences of COVID using these sorts of approaches. I'm going to stop at this point. So what I've tried to tell you, and as I said, I'm aware there's quite a range of people on the call in terms of your expertise, but I've tried to explain to you a little bit about what the short and the long-term effects of COVID-19 are. And both of these, I think, are really important. Assuming we're able to go with a big vaccination program and start to reduce the numbers of cases coming through, the biggest burden on the healthcare system will probably be the long-term consequences of COVID, although I think it's highly likely that we will continue to see small numbers of cases every year. This isn't a disease which is going to go away, I don't think. It's likely there's always going to be some of it around, and we may well end up a bit like flu with an annual vaccination program, I suspect. That's just a guess, I don't know that, but that's what I think will probably end up happening. I hope I've shown that the biomedical research centres across the country, but in Nottingham in particular, has helped to coordinate the local delivery of many of the national studies, which have actually provided us with a lot of information, which puts us in a far better place now to manage patients with COVID than we were when this disease first appeared in China back in January. And I've told you a little bit about the Norcourt platform, which we set up specifically to support some of the unmet needs, particularly on long COVID, particularly focusing on populations who up till now have received less attention. So those who didn't end up in hospital, so those in primary care. And we've also got studies looking in care homes. And this has actually, as I said, generated a surprising amount of interest from both academic and industry partners. And I've told you about some of the studies that we put in place through the Norcourt platform to try and drive things forward and pump prime other larger projects. So that's sort of an oversight of what we've been doing and where we are. I hope you found that interesting. I'm very happy to answer any questions, and Charlotte's, I think, still on the call as well. I'm sure she'd be happy to help answer your questions as well. So I shall stop screen sharing at this point, and I will hand you back to Kate.
Lovely. Thank you so much, Ian, for such a fascinating and insightful presentation there. Really, really interesting. And I can see some people nodding there in agreement. So yeah, really fantastic. Thank you for that. We have had a number of questions come through. You'll be glad to know. And what
I can see some in the chat.
Yeah. Yes, we have had a few questions. So what we'll do now is we'll go into our Q&A session. I did invite people, if they wanted to ask the question themselves, you are more than welcome, but I understand if not. So I'll go to the first question we had in the chat, which is from Jill, and it basically states, how far do symptoms experienced by an individual in the acute phase of COVID match their ongoing symptoms of long COVID, or do new symptoms appear? I don't know, Charlotte, Ian, would you like to provide a response to that?
So I think, Charlotte, do you want to go first on that one? It's in your space, isn't it?
Absolutely. So, I mean, we're early days of still understanding that, and that's not the get out excuse. I would comment that probably under this long COVID name, there are a number of different types of patients that we're seeing. We're seeing the patients who are discharged from hospital or after intensive care, and generally their symptoms are ongoing, if they are, or gradually improving. What we're seeing with a new clinic are patients who didn't come into hospital. And again, the vast majority of their symptoms are ones that presented initially and haven't diminished, but there are certainly some patients reporting new symptoms occurring.
Thank you, Charlotte. Yes, thank you very much. Jill, I hope that answers your query. I can see, yeah, nodding. Thank you very much. Lovely. So I'll move on to our next question now, which is from Sarah. And Sarah's asked, does the research into long COVID include studies on how applied health practitioners, such as occupational therapists, can support these patients to recover?
That's definitely Charlotte again, I think, because it's something we've talked about a lot.
Absolutely, it should be. Absolutely, that's what we're working towards. Occupational therapists is one of the allied health professionals alongside nurses, doctors, physiotherapists, speech and language, dietetics, you name it. There are different, I think the other key thing to get across is there are different needs that patients are presenting with and different symptoms. And whilst we can't 100% individualize it, we need to be meeting the needs of the patient, both in what we know and what we can offer, and in terms of the research. And again, I'm going to use an umbrella term, but there's a large focus of this is on rehabilitation of some sort. The exact minutiae of what that rehabilitation is the context of some of the research, but absolutely occupational therapists who help people, enable them to get back to work, enable them to get back to what they were doing before, or assist in improving, making it slightly easier. I mean, I've been overwhelmed with how the occupational therapist can help me clinically in the clinic, addressing this brain fog symptoms, but also really good ideas of enabling patients to improve. But there's an awful lot more we need to be addressing with research alongside.
Thank you. Thanks for that answer, Charlotte. Much appreciated. Lovely. Okay, I will move on to our next question, which is from Sue, who has stated that she is currently experiencing long COVID symptoms. And she is struggling to find some help, some medical help for this. And so she'd be interested to know how she can participate in research or receive some medical help in Nottinghamshire. However, she doesn't live in the Nottingham area. So I don't know if you might have some advice for Sue.
I mean, I guess I'd say I'm sorry you're sort of struggling to find the help first off. I think a number of us recognise there is patchy current provision of clinical and research across the country. There are some measures coming in. You may well have seen on the news comments of these long COVID clinics and a number of centres to be set up, a lot of unknowns at the moment. In terms of participating in research in the Nottingham area, I'm pausing. We have, because all of this has been done, so the setup, I guess what we've wanted to do is to open up what we can as fast as we can in a safe way and meeting the needs of what patients are reporting to me and to Ian in clinic. What I guess there is potentially another opportunity is to open up that wider. But at the moment, most of the referrals for the research is through the clinical service in Nottingham, which tends to be from GPs in the Nottinghamshire area.
Yeah, I mean, you know, I don't want to sort of get into individual medical details or anything here, because that wouldn't be appropriate, clearly. But a little bit depends still on where you live. But for example, some of the imaging studies that we're doing, it might be that you would be suitable for one of those if you're interested in the research side. I can't pretend that's going to improve your sort of medical condition by being involved in that sort of project, but you know, I'm sure if you passed your details on to Kate after this meeting, you know, we could contact you separately if you were keen to do that. Clearly, with the tiered systems coming in, then a little bit will depend on whether you can travel between tiers, etc. And we wouldn't want to try and promote people not sticking to the restrictions, obviously, but potentially, if you'd be interested, we'd be keen to hear from you.
Yeah, thank you both. And yes, Sue, I do hope that goes away in answering your question. And what we will provide you with at the end is a contact detail for you to contact us. It's myself at the end of the email, so it'll be me, and we're more than happy to answer any more queries and help you a bit more specifically with that. So thank you very much for your question and your answers, Ian and Charlotte. Okay, I will move on to the next question now, which is another one from Jill. Jill has asked, is anyone taking up the challenge of social and psychological impact of long COVID, and what can be learned from other chronic diseases?
Shall I go first, Charlotte? And then perhaps you'd like to say a bit about what you're doing through the clinic. In the BRC, we have a mental health theme, and it's not part of NUH. It's actually part of the Notts Healthcare Trust, really. But we cover both organisations. So they are involved in a couple of big national studies looking specifically at these issues. Particularly more on the psychological impact rather than on the social impact. So there are some research studies which we're involved with, which are starting to address some of these challenges. I mean, clearly, this could well turn out to be one of the most important areas, both in terms of the short term and then, on the social side, what we're inevitably going to see is rises in unemployment, etc. So at a societal level, there are going to be some really significant economic consequences which will feed through into jobs, and all those things have indirect effects on health, of course. But Charlotte might like to say a little bit more about what we're specifically doing through the primary care clinic that we've established.
The primary care clinic, again, we're trying to understand, but we're trying to do more than just do a tick box exercise of, yep, we know a little bit more now. We are seeking to involve psychology support to address these issues. And that's not, that's putting psychology in its alongside the other symptoms that patients are presenting with. But we, referring to the other part of your question, we know from other chronic diseases, and my experience predominantly is in chronic lung disease, that there is an important allied element of psychological impact for patients there. I think I'd also comment this FOSP study, or post-hospital PHOSP study, which I'm involved in. That's for, as the name suggests, post-hospital. But again, there is an important psychology and psychiatry working group there who are developing further studies to understand that side. And a colleague of mine is in that group and has approached us about looking at some of the psychological aspects of returning to work and some of the challenges, both physical, psychological and social, associated with that. Primary care wise, I think there's an awful lot we can be doing and should be doing. A lot of patients on the clinical side report the frustrations that back in April, May, they never had a swab. Yet their symptoms are real, they are persisting, and I guess an element of frustration and a lot more are elements alongside the physical symptoms they describe.
Thank you. That's a really comprehensive answer, and actually it links in very well to the next question posted from Neil, who has actually asked how much attention is being directed at people who have had mild symptoms initially and weren't tested initially, so they never had a positive test, and weren't admitted to hospital necessarily, but are now really struggling and have gone on to develop long COVID symptoms. So I guess those in the community who maybe didn't go through the routes.
So I mean, the situation was entirely different in April and May, and Ian's graphs show that swab testing wasn't as available as it is now, and the general advice, if you were well enough, was to stay at home, isolate, assume it was COVID, and 10 days later people would recover. Clearly, for those that haven't fully and are seeking advice and medical assistance now, there is this frustration that I share with patients in that they haven't got this positive swab, yet that was the situation then. In terms of research, we recognised in different ways, both myself and Ian and colleagues, that actually this needs to be the focus alongside the people discharged from hospital. So we're doing what we can, and we've set up the NORCORP in the last 4 to 5 months to begin to address that. Nationally, that's not the case. And so we're very fortunate that we can be driving that locally in a small but deliberate positive way forward.
I think so. A couple of things I might just add to that. So if you didn't have an initial positive test, then in theory, if you still have an antibody response, one will be able to find out whether you've had COVID or not based on an antibody test. Now, at the moment, they're not being done routinely, although they are forming part of a number of research studies. So I haven't seen what's going to happen about this, but one of the key questions I think which will come up when we start to look out at the rollout of a vaccine approach is that in the vaccine trials, we tested everybody before they were given the vaccine to see if they'd already had COVID, because there was little point in giving them the vaccine if they already had. I haven't seen anything to suggest that when vaccination is rolled out nationally, there's a plan to do serology testing to look to see if people have got antibodies. But it would seem to me to be logical to do so. We know, in different parts of the country, the rates vary, but in some parts of the country, getting on for about 20% of people have got antibodies to COVID. And so you could get away with vaccinating 1/5 less of the population if you could identify those people. So there would be logic in doing so. So it's I can't promise this will happen because I don't know that it will or it won't, but it's possible that people might actually do some antibody tests on people who had symptoms back in the spring to see if they've still got antibodies, in which case you might find out whether or not you've had it or not.
Thank you very much. Yeah, again, really comprehensive, and I think again I would advise Neil, for more information and how we may be able to help you specifically, please do contact us through the details we'll provide at the end of the session, because we are here to support, and this is what we want to do, and one of the aims of these sessions. I'll move on to the next question now, which is from Michael, and Michael has actually asked if he can be invited, hey Michael, to ask the question himself. So thank you very much, Michael. Would you like to ask your query to the panelists?
Thank you, Kate. Yeah, good evening, and Ian, thank you very much for a very interesting presentation. My question is to do with long COVID. And I mean, I know partly through my own healthcare experience that for many years, long before COVID, there has been talk of long-term debilitating conditions that follow from acute viral infections. And more recently, we've heard of the conditions CFS, ME, and also fibromyalgia being used to provide labels for people with those sort of long-term after effects of viral infection. Is there any overlap from what we know about long COVID between that existing knowledge of viral infections and coronavirus, or is long COVID something very, very different as far as what we can tell so far?
Thank you, Michael. Charlotte, Ian, would you provide any?
Sorry, I'm going to be deliberately vague, and I'm sorry, I don't mean to be. I think there's a number of viruses that cause a post-viral condition of differing sorts. For example, glandular fever, a number report this prolonged post-viral symptoms, and I guess I'm probably going to stop at post-viral symptoms. I don't think we know enough about labelling it as chronic fatigue syndrome, ME, or fibromyalgia. Certainly the symptoms of fatigue or symptoms similar to a fibromyalgic state are there. Whether they are wholly overlapping, we're not at a stage to know. Certainly the research we're doing within Dynamo, where we take a number of muscle measurements looking at both strength, a certain amount of endurance. We actually invite people to have a muscle biopsy. We're trying to understand far more about the mechanisms behind the fatigue that patients describe following COVID. It's not going to be comparing it with chronic fatigue syndrome and ME, but there's so much to know that I think we need to be really careful of assuming things are the same or overlapping dramatically at this stage. I don't know if Ian's got more.
Yeah, so I've talked to my colleagues in the mental health team in the BRC about this specific problem. I think there is some anxiety amongst colleagues that that long COVID is just going to get labelled as ME, to be honest, and at least indications that there might be some overlap for some patients. There are groups of patients who don't fall into that sort of diagnostic sort of bucket, if you like. So, and I think it's quite dangerous because if there are long-term inflammatory consequences of COVID, which are driven by biological mechanisms, then we need to know about them. And actually, there's the potential that if we do learn about those, it might actually inform us a bit more about, for example, the post-glandular fever fatigue type syndrome, which Charlotte just mentioned. So I think there's a huge amount to learn in this space, and COVID might just be the trigger to make some real progress in what's been a very difficult area for research. And so I think it's very challenging. It's a very challenging area to do research into, but I think that, long COVID might be the stimulus which gets us through to some significant changes.
Thank you both. And Michael, thanks again for putting that question to the panelists. I hope that helps answer your question. Yeah, perfect. Thank you very much. Okay, so I'm moving to the next question, which is actually talking about, asking about one of the many symptoms that can be associated with long COVID, and that is long COVID symptoms have been included with gastrointestinal problems. What do we currently know about these symptoms?
I could make a stab at that if you like. So one of the interesting things which we learned was that presentations for acute COVID weren't always classical. So, if somebody came along who got a new dry cough, lost their sense of smell, got breathless and was hypoxic, that was, fairly straightforward to diagnose. But particularly, I think in the elderly, we saw people presenting with all sorts of constellations of symptoms which didn't sound like COVID at all. So we saw people presenting with acute abdominal discomfort and with diarrhea, etc. And so it's absolutely clear that the SARS-CoV-2 virus, which is the virus which causes COVID, can cause inflammation in other organs other than the lungs, I've already said, and the gut is clearly one of those. So whether or not that's going to lead to long-term consequences isn't clear at the moment. I've been involved in some of the research we've done in Nottingham historically, looking at irritable bowel syndrome. So there are a substantial proportion of patients who report irritable bowel syndrome who turn out to have low levels of inflammation in the gut, and usually this has been precipitated by an episode of infection. So if I had to guess, and I don't know, this isn't based on any fact, it wouldn't surprise me if we start to see people who have sort of irritable bowel syndrome type symptoms coming forward. There may be other low-grade inflammatory changes in the gut. It's too early to know. The sorts of MR imaging studies that we're doing will provide some insight into that, because one of the things that you can do is you can measure inflammation in the gut using MR imaging these days, and so that will give us some sort of insight, hopefully, into. We haven't done those studies yet, but I think post-hospital COVID is going to do some imaging looking at the gut, isn't it, Charlotte?
I believe so, and I mean we're certainly trying to incorporate a little bit of imaging of the liver, which again may be related. One of the striking things is people reporting quite marked weight loss, and obviously the appetite, which goes with a lot, an awful lot of viral illnesses, and then trying to understand how we can encourage that regaining weight where needed, be it muscle or generally.
Brilliant. Thank you very much. Again, stressing the importance of imaging, as you mentioned in your presentation, Ian, into the multitude of symptoms people are experiencing. Thank you. Okay, so the next question we have is, and I don't know whether you will be able to share any information on this or whether you will know specifically, but it's asking whether there are any preliminary findings from the study on pregnant women with who are COVID-19 positive.
So I can take that one. So thanks, Om. It's lovely to see you on the call, actually. So the simple answer is that there are two parts to that, aren't there? The first is the effect on pregnant women, and then there's the potential consequences in terms of their babies. So I think we do know, as a consequence of the pregnancy cohort studies, about pregnancy. So pregnancy doesn't seem to have an increased risk for poor outcomes with COVID. And obviously most people who are pregnant are women and are young, so therefore they're going to be in a well, they're all going to be women, but they're in low risk categories anyhow. So it doesn't look as if you're at particular risk as a mother from COVID because you're pregnant. So the question, there are some anecdotal reports, but not come out of the study we're doing, I have to say, but I have seen anecdotal reports about the potential for transfer of the virus across the placental barrier. And so whilst I think it's unlikely that there are going to be any long-term consequences in the babies of people born from mothers who've had COVID-19, I guess the simple answer is we don't know at the moment. So those follow-up studies will need to be done. I'd be pretty optimistic there won't be any consequences, but you know, I guess we just have to do those follow-up studies and find out.
Thank you very much. Okay, so we'll move on to the next question, which is from Vanessa. So Vanessa is asking whether the research and the outcomes and recommendations from this research is being passed on to GPs, and has shared a bit of experience around an element of GPs maybe not understanding the symptoms of long COVID and therefore maybe not understanding how to help and support and treat these patients. I don't know, I think Charlotte, I can see you nodding your head there.
So I mean, I guess we're covering a number of different research projects here. What I can report back is in a few. In terms of the more breeding related GP referral clinic, there absolutely is a comprehensive clinical assessment of what could be causing the breathlessness in the patient, and we try to do some tests alongside to understand what could be persisting from COVID, but sometimes actually what could be undiagnosed asthma, but I certainly would remove the just from it. What we try to do is to understand what is causing the symptoms, what we can do something about, and in that clinic, both the NHS part of it, and if the patient gives permission, anything of clinical relevance will be fed back to the GP. What I would cover is in that clinic and also in other research projects, we are trying to understand a lot more about how COVID's affecting a person, the mechanisms, and not everything we do is of clinical relevance. So, for example, some of the MR studies that I'm involved in or peripherally involved in wouldn't necessarily feed back every single line of the report, but if there was anything of any significance and the patient gave permission, then yes, if we detected something, that would be, it's our duty to pass it on or deal with.
So a couple of things from me. So the first is the asthma bit. So I run an asthma clinic, and I see a lot of patients referred who've had some sort of upper respiratory tract viral infection who are left with cough, a bit of wheeze, etc., for sort of 6 to 12 months afterwards. And that's going back years, so that predates COVID. So there's no doubt in my mind that a viral upper respiratory tract infection can lead to what we call airway hyperresponsiveness, which I guess is an asthma-like set of symptoms, but usually those go away over sort of 12-month window or whatever. I would be amazed if we don't have the same group of patients who've had COVID, because at the end of the day, COVID has caused a nasty upper lower airway inflammatory insult, exactly the same as many other viruses like RSV and things like that. So I'd be pretty sure that some of these patients will actually have some asthma. The second point I'd make is it's been very difficult, I think, for many of us in terms of how to interact with patients. So, you know, most of my clinics are based on telephone consultations, as are indeed many GPs clinics. There are some tests which have been particularly challenging. So historically, we've done lots of lung function testing. Unfortunately, lung function testing, just measuring, you know, what your lung volumes are, etc., classes as an aerosol generating procedure. And so there are significant restrictions have been imposed in terms of our ability to deliver those tests, which have reduced the number of people who we can do testing on. So that has produced some challenges for us. I think things will get better with time, but I think that the system's still quite perturbed, and it will take a little bit of time for GPs, clinics to settle back down, routine lung function testing, etc., to settle back down, and indeed for us to work the optimal way to manage the sort of post-COVID primary care clinics.
Thank you both. Yeah, a really comprehensive answer there, and kind of highlighting some of the practical issues that that everyone has faced during the current circumstances. Okay, I think we are on to our last question, unless anyone wants to fire away any more into the chat. Please do feel free, we have still got some time. The question is from Teresa, and she has asked, how long do you think that it will take to get full immunity from a vaccine? Have you met many patients with pulmonary fibrosis? Oh, I think that's a follow-up. Let's do the first one first. So
well, I'll do the first one. I'm happy to answer the second one, Charlotte, or you can do the second one if you want. So the vaccines are complicated. I think I mentioned when I was talking there are more than one sort of vaccine, but what's become clear as we've run the vaccine studies is that getting the right dose of vaccine and the timing of that dose right is really important. It looks like for anybody to have an effective response, you're going to need to have an initial vaccination, then a second one 4 weeks later. You start to see antibody responses by that 4-week period, but to get full immunity, it's going to take longer than that. So my best guess is that 4 to 6 weeks is the soonest the quickest period you're going to have before you start to see practical levels of immunity following a vaccine. The next thing to say is that the preliminary data that have been released suggests that with the RNA vaccine that Pfizer have studied, something like 90 to 95% of people have effective immunity after that period of time. The levels look like they're a bit low with the Oxford vaccine. When you go out into the real world, because I think the patients in these studies are relatively selected groups, it may be that the overall level of immunity is slightly lower. Having said all those things, the way to think about the vaccines is that anything which, well, we said when we set out to look at the vaccines, anything over 50% would be beneficial. My way of thinking about it is if you have a virus which has an R value of 3, which means that every person who's infected passes it on to 3 other people, if you can reduce that R level down below 1, eventually the virus will die out in the population. And so what that follows from that is that if you had a vaccination effectiveness of over 70%, that would have the effect, if you vaccinated everybody, of driving R below 1. Now, we won't be able to vaccinate the whole population very quickly, and there'll be people who won't, for one reason or other, get the vaccine. So it would be good to have greater than 70% effectiveness. But I think that for all those reasons, we will find that we will get a fair amount of immunity in the population over time as we increasingly vaccinate large numbers of people, which is why I say there's light at the end of the tunnel, because I think this would drive COVID down to being a seasonal illness with relatively smaller numbers of individuals involved. There are a few uncertainties. We think that the antibody response is okay in the elderly, and clearly the elderly are the people who are at most risk from this. So having an effective vaccine which works in the elderly as well is important, but we haven't got enough cases in the elderly population in the clinical trials yet to know for certain how effective it is at preventing cases, which is what matters, not the antibody response. So there's some uncertainty still, I think, about that. And I suspect that there are lots of other vaccines in development, and so it may be that there's a trade-off between how easy it is and the cost actually of giving a vaccine versus the effectiveness. So at the moment, the two which are like to get rolled out in the UK, the Pfizer one looks a bit more effective, but it's much more difficult to give. For those who don't know on the call, you have to store it at -80 degrees centigrade, whereas the Oxford vaccine can be stored in a fridge. So it's obviously much easier to administer it to large numbers of people. So I'll stop there. That's my sort of views in terms of the vaccine. We don't know how long it'll last for either. That's the other question about it.
Oh, sorry.
Yeah, go ahead, Teresa, and then we can go on to the pulmonary fibrosis one. But
yeah, presentation as well. It was excellent. But say, for instance, a patient goes for it and has the first part of the vaccine, and then they don't go for the second.
Yeah.
Do you think that?
My guess is it won't be as effective. I mean, the reason, so when the Oxford study was originally set up, they changed the vaccination protocol because the early antibody responses were showing that unless you had this two-step process, then you don't get the full antibody response. So they might get some protection, but it's going to be limited.
Thank you.
Thank you. I believe that the pulmonary fibrosis question was from yourself, Teresa. So I don't know. Would you like to ask it to the panelists? Or
I was just wondering how many patients you'd seen with actual full, following ARDS, a good pulmonary fibrosis picture, and was it in patients with respiratory conditions to start off with, or?
Do you want to go first, Charlotte, and I can fill in if necessary?
Yeah, sure.
I'm thinking long term, Charlotte. Rehabbing them and actually looking after them, over the coming months.
So across several hundred patients that myself and colleagues have phoned and followed up on, and I'll vouch for the followed up on, following a hospital admission. So we phone patients who were admitted to the respiratory wards. We see how they are and assess how they are, but we also then check to make sure any x-rays don't need repeating, any bloods don't need repeating, and that sort of thing. But across those several hundred, we've seen very few in Nottingham with any picture of fibrosis. And for those wondering, a fibrosis is where there's some thickening within the lung that perhaps are not as elastic as they should be. The lungs can't expand as you would expect them to when you take a deep breath in and when you breathe out. We've seen a few. We've seen a few who have had an intensive care stay where they've had ventilation. They may have had a prolonged stay. They were extremely sick because that was why they were on intensive care in the first place. They may well have had a number of medications. And the numbers are probably too small to really sort of cut much further, but generally they aren't people without respiratory illness. We have seen a few others who didn't have intensive care, and they have what I'd probably at this stage, as far as we're aware, a little bit of scarring. And that scarring is fibrous strands within the lung. But we're not seeing the classical active inflammation that's developing and worsening over the short period of time we've been able to follow them up so far. That has been a concern, and it remains a concern, but I'm pleased that we're not seeing it in the high reported numbers. And I say it looks to be some scarring. We're taking them seriously, we're assessing them, and a key thing will be to monitor them longer term to just check that's the case. Some patients clearly, if they had underlying lung condition, if they had underlying thickening of the lung to begin with, some fibrosis there, then actually the COVID has affected them worse than it's been one of the risk factors for developing worse disease, and will take longer for them to recover. And certainly if you had underlying chronic lung disease, you then have COVID, you then have a prolonged recovery. For them, I think rehabilitation, the standard pulmonary rehabilitation that we offer patients with chronic lung disease is there on offer. For those that didn't have chronic lung disease before, I think there's a big question as to what that rehabilitation encompasses, hence the research.
So I haven't got much to add to that, Teresa. Really. I mean, I think Charlotte's explained it very. So I guess what follows from that is, given that we're not seeing lots of really nasty fibrosis in patients, apart from the odd one who's been through ICU with a sort of ARDS-like picture, I guess what follows is why are people quite breathless, and B, is there anything different about COVID? So we don't know yet the answer to the first bit. That's obviously what some of the research is aimed to do. The second bit, so one of the things that, if you look at the patients who went to ICU, is different about COVID compared with other viral pneumonias like flu, is a much higher incidence of clotting abnormalities. So for those who are medical on the call, what we saw was that a lot of blood clots formed in blood vessels all over the body, actually, which is probably one of the mechanisms whereby people got kidney failure, for example. But this can also affect the way that the heart and the lungs work together. And so I wonder if quite a lot of the breathlessness is been related to those thromboembolic complications, those blood clotting abnormalities. Don't know that for certain yet, but imaging would be a good way of looking at that in more detail. And I was talking to one of my colleagues who runs the pulmonary embolism follow-up clinic, and he's had an awful lot of referrals of patients who've had COVID and who've gone on to have blood clots in the lung, pulmonary emboli. So
really interesting. Thank you.
Absolutely fascinating. Yeah. I do know, because we're assisting with some patient involvement at the moment into a COVID study looking at blood clots or organ body blood clots. So again, there's so much unanswered questions, but this is hence the importance of researching answering these questions.
Are you using prophylactics? Thank you, Katie. Are you going to are you using prophylactic anticoagulation then?
Yeah.
During the inpatient stay, we've been giving anticoagulation, and we've probably had a slightly lower threshold than general, because we know there's a greater risk. On discharge, it's encouraging people to keep as active as possible. But certainly what we've had is a much lower threshold of investigating.
Yeah, lovely. Thank you. Thank you so much for your questions there, Teresa and both Dean and Charlotte. We have had one more question pop in, which I think we can squeeze into the last few minutes of the session. It's from Om. And it is directed at you, Charlotte, if that's okay. So when do you advise to start pulmonary rehabilitation to have maximum effect for those who have been discharged from hospital? Put you on the spot there.
No, I don't mind at all. I think we've got to first off question whether pulmonary rehabilitation is the correct thing. We need rehabilitation to address the needs of the patient, and certainly not all of them are respiratory limited. I've been involved in some of the British Thoracic Society guidance, and it's as evidence-based as it possibly can be, which means not a lot. There has to be time for a patient to recover from the acute COVID, and we can't underestimate that. And during that acute phase, they may well need some assistance with physiotherapy, getting around the house and things like that, and that sort of rehabilitation, and we can't underestimate that. In terms of potential classes, whether we class it as pulmonary rehab or an adapted pulmonary rehab, I think we've got to look at, you know, potentially a couple of months down the line in terms of classes. Classes has got its own challenges, because how do you bring a whole load of people together at the moment in one venue and then get them exercising, keeping socially distanced and all that side of things? There are some measures to try and support people doing some activities at home. And certainly what I would encourage is the earliest you can keep to a certain level active, but not overdoing it, the better. And if you actually notice the activity is making symptoms worse, then to go at a slower pace. But certainly keeping as active as possible is crucial. The pulmonary rehabilitation, that's a working group I'm involved in this FOSP study. And there are certainly key things we should be looking at. But again, there's just so much we don't know. And we need to be careful we don't make things worse by just, again, clumping everything together and assuming.
Thank you. Thanks for really fascinating stuff. Yes, and well, Charlotte has just posted, are you aware of the Nottinghamshire COVID survivors support group who are running virtually? Yes, and I do believe there are an array of support group. I know Self-Help UK have a long COVID-19 support group as well. And we are linking in with these groups to help support our research. I don't know, Charlotte, if you want to.
Just briefly, yes, I'd encourage that whilst the rehabilitation or the exercise element of rehabilitation is one question, certainly peer-to-peer support at this time, particularly when there's so much unknown, I completely endorse.
Brilliant, brilliant. Thank you very much. And we are coming to the end of the session now, and I just want to thank everyone so much for participating, for being open with your questions, to our panelists, and again to Ian and Charlotte for providing, you know, information sharing and providing your expertise. I've certainly found the session fascinating and insightful, and I hope that everyone here has as well. I don't know if you want to make any finishing comments, Ian and Charlotte, before I just provide kind of some next steps.
No, I hope people have found it useful. We tried to sort of provide a local perspective on things which are, you know, nationally important. Just one brief thing I was going to say. In a future session, I think probably of this, we'll be interested in addressing people's views on what research priorities in the medium term we should be taking forward in Nottingham. So I have a particular process to go through, which is to renew the funding for the Biomedical Research Centre, which is probably going to kick in next year after Easter. And one of the challenges for us, I think, is going to be to get the balance right between the COVID-related research we're all doing and the importance of non-COVID research. So one of the things I really worry about is that because there's been so much attention on COVID, an awful lot of research in non-COVID areas, and actually a lot of medical care, you know, cancer screening, heart failure screening, all these sorts of things has been more difficult. So I think there will be a lot of consequences of that potentially. And so we'd be very interested to hear people's perspectives and views on what the really important questions from everybody on this call and indeed elsewhere's point of view, rather than what I think are the most important questions. So any input into that process would be welcomed. And I think Kate's probably going to organise a future session to address some of these challenges. Thank you.
Yeah, thank you, Ian. Absolutely. I was basically just like a nodding dog there as you were saying all of that. Absolutely. We're really hoping to utilise the Research Lounge and these open conversations to look at what we should be prioritising. So really, what matters to you and what we should be focusing our research on. So watch this space, and we will be circulating information about that shortly. And again, just want to thank you again for contributing. This is so important to have these conversations. So just want to thank you and know that it's truly valued that you give your time to speak with us. We are coming to the end. I know it's an hour and a half, quite long, sat in front of a screen. So I want to thank you again for your engagement. We will be sending out an email following the session. It includes a feedback form, so please do give us feedback, anything on how we can improve the session, you know, any suggested topics for future sessions are greatly welcomed. And what we'd also like to do, following on from this session, is really to ask you what you think our priorities should be in regards to COVID research and long COVID research as well. So we will be asking you, and if you would like to submit, you know, what questions do you think our researchers should be answering, then please do let us know, because again, it's greatly valued, and your input is greatly valued. So that's it from me, really. And I just want to thank everyone again. Thank you, Charlotte. Thank you, Ian, everyone for attending. And I'll let everyone go and have a nice evening now and have your dinner, I assume. So thank you very much. Waves to all. I'm going to put a slide up now which just has our contact details at the involvement team. So any further questions, then please do not hesitate to contact us. So yes, thank you.
Thank you
very much.
Thank you very, very much. Very interesting.
I hope you have all enjoyed the session.
Yeah, very much. Very much.
Very good. Very music to my ears.
No,
well worth it. Yes, lovely. Thank you.
Thank you, Claire. It's lovely to see you as well.
Yeah. Well, it's good to hear all this. It's great, you know. Thank you very much indeed.
That's no problem at all. I hope to see you at the next one.
Hope so. Very much hope so. Okay then. Bye, Kate. Bye, everyone.
No problem. Thank you. Hope to see you
Bye.
soon.
Lovely to see you. Ian. Take care, Charlotte. Bye.
Oh, wrong. There we go.